Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. Thank you for joining the Weekend Educational Series. Today, Amanda Didier and Dr. Judy Guinn will discuss initial approaches to children who may have been maltreated, developmental considerations. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. To ask a question, you can use the question pane on the control panel. Questions will be addressed at scheduled breaks. To obtain continuing education credits for today's session, you must track your attendance by texting today's code to the phone number on the screen. The code and phone number will be displayed at the end of today's session. This training has been approved for MOC Part 2 continuing education credit hours. You must complete a knowledge quiz at the end of this training. The link to the knowledge quiz will be displayed on the screen. After reporting your attendance, you should log into your account at ocpe.mcw.edu and complete an evaluation within 10 days. To view step-by-step instructions on claiming continuing education credits and to see a list of future webinar topics, please visit wichildabusenetwork.org/webinars. Now we will proceed with today's presentation.
Well, hello, thank you for joining us. This is Amanda Didier, and I have Dr. Judy Guinn with me. And we're going to go through talking about how to handle cases of allegations of child abuse when a child is presenting to a provider. So we'll start with some brief introductions.
Hi, everybody. I'm Judy Guinn, child abuse pediatrician at Children's Wisconsin with the Child Abuse and Protection Services. I do medical evaluations on children who are suspected to have been sexually or physically abused or neglected. And I work both at the hospital and at the child advocacy centers in Milwaukee and here at Lakeshore in Saukville, Wisconsin.
And I'm Amanda Didier. I am the Executive Director of the Lakeshore Regional Child Advocacy Center, which primary location is in Saukville, Wisconsin, but we also have a satellite location in Sheboygan. I'm also a forensic interviewer of 16 years, and I am one of the founders of the Lakeshore CAC. So to start, we're going to talk just a little bit about a framework about child advocacy centers and the terms we'll be talking about today. So one of the terms we'll talk about is a multidisciplinary team. This is, for the purposes we're talking about today, means that the group of individuals that are involved in child abuse investigations. And we'll dig into that a little bit more and what that means. We're also going to talk about forensic interviews, which is a recorded interview with a child or a vulnerable adult who is suspected to be a victim or witness to a crime. And we're also going to talk about child advocacy centers, which is the place where both Dr. Guinn and I work. And there are 15 in the state and 1 satellite and several more kind of in the works. So it's a term that if you're not familiar with, you're going to be hearing more and more about them as time passes. But I think at this point, everyone has access to one in the state. It's just some have a longer drive than others. So our hope is that we're going to be able to reach all children in need of our services through the CAC movement in Wisconsin. So multidisciplinary teams, as I said, are a group of people dedicated to one common cause. This, for example, and this is actually an outdated picture. If I showed a new one, it would be all Zoom screen like Brady Bunch. But this was the Ozaukee County Drug Endangered Child Task Force. So there are representatives visible from the District Attorney's Office, Victim Witness, Human Services, and several police departments. So this group is tasked with reviewing, handling, and creating a protocol for any cases that involve children and use, manufacturing, or distribution of drugs. So it's a group that meets quarterly and is able to accomplish a lot of really great things because they come together and work together. So each county that has a CAC has a multidisciplinary team that is dedicated to child abuse. You may or may not be part of that team, or you may by extension be a community member that is associated with a team like that. So child advocacy centers are really what sets them apart from other kinds of programs that are similar is that they are safe, they're neutral, and they're family friendly. So when we think about where we want a child to be seen, to both be interviewed, to have their family receive advocacy, and to have that specialty medical exam, a CAC is really at the middle of a Venn diagram. I should draw one, but essentially, like if you look at those three qualities, safe, neutral, family friendly, yes, children can be interviewed at a school, but is that neutral? Yes, children can be interviewed at their home. Is that neutral? Is it safe? Yes, children can be interviewed at police departments, but is it family friendly? So really what we're looking at is to create the kind of atmosphere that provides the best opportunities for families to heal from trauma and to get the services they need to feel safe and be on the path to resilience and healing. So the CAC model, we talked about that MDT, and a CAC is home to that MDT. So this is an example of what that looks like for those that need a visual. And then a case example, and this is a really important one. So I'm going to talk through a case that has happened since the onset of COVID to give you an example of how CACs work, why they're so crucial, and why you as providers are so crucial as well. So there was a child who was doing all virtual schooling, and she had a twin brother, and they were at home with a single father. And the child went in for a well child visit. And during the course of her checkup with her pediatrician, the pediatrician asked if she had any concerns, which I believe is a pretty general question for a pediatric exam.
Yeah.
And the child said, well, my brother keeps sexually abusing me and he won't stop. So, obviously this was not the answer that the pediatrician was expecting, and it launched a whole process of a child abuse investigation that resulted in the child coming to the Child Advocacy Center, both for a recorded interview to memorialize her statement in the most legally defensible way possible, but also an exam with our provider, Dr. Guinn. So for those of you that don't know what Dr. Guinn looks like, that picture is actually of her. And that's the room at our CAC. We do need to decorate our walls.
Yes.
And that is actually one of my daughters, Harper. So it's not a picture of an actual patient, just so everybody knows. So, but the reason I wanted to share this story is because what we saw as a trend during the pandemic is that children lost their access to the primary mandated reporter of child abuse, which are teachers and school personnel. So what we found, which was really surprising, but I guess in retrospect makes a lot of sense, is that reporting was down during safer at home orders and the like, about 20% for child abuse and for domestic violence. However, what we did find is that children still were disclosing, but they were having to find increasingly creative ways and have to find safe people to disclose to. In the case of this young lady, she told her pediatrician, because that was her first access outside the home to a mandated reporter. So that's what she had to do to keep herself safe. So, your role and how you're involved with children is more important than ever, because even though many children are going back to in-person schooling, I think that virtual as an option for many areas is going to be something that is around to stay. And we really want children to have access to adults that can keep them safe. And the fact is that over 90% of children are abused by a household member. So that means that 90% of children who are abused have or are in the home with that abuser. So more than ever, these children need all of us to be ready, to be listening, and to know how to respond if they make a disclosure. And that's why CACs are here, is that we're vested in healing for the family. Advocacy is a part of our programming, and interviews, medical exams, a bridge to mental health services, and really promoting this overall case coordination. When a child goes to a center, such as the one who disclosed her brother was abusing her, law enforcement came to the appointment, human services came to the appointment, a community advocate for the father came to the appointment. The medical provider, Dr. Judy Guinn, was here for the appointment, and our forensic interviewer was also here. So everyone comes together, and it creates better case outcomes and for the family as well as for the investigation. So forensic interviews I already touched on briefly, but these are the 4 main tenets of forensic interviews. But the most important pieces to take away, I think, are that we're looking to minimize any additional trauma to a child and maximize the amount of legally defensible information. That is our interviewer, Sam, at Lakeshore CAC, and she's also our satellite interviewer. And then that's my other daughter, Molly. So I do subject them to being part of our advertisement. They have consented. So that is them. So how are children involved and how do they end up here? I just briefly wanted to touch on that. It's not just sexual abuse. Sexual abuse accounts for about 70% of the referrals to the CAC here at Lakeshore. However, there are many other ways that children end up here for medical care or forensic interviews. Obviously, physical abuse, but neglect is also one that we see a lot. Drug endangerment, again, is becoming increasingly common for children to come in for. Witnessing violence and witnessing other crimes. Even more serious crimes such as witnessing a homicide or attempted homicide. Those are kids that would come to a center like ours. So shifting gears a little bit, we want to really talk to you today about what happens if a child comes to your office and you find out that there's concerns of child abuse. And sometimes that might be why the family presents to your office, because they're concerned, and Dr. Guinn will talk about that extensively. But also they might be coming to your office about something totally unrelated, such as in the case of the young lady I talked about earlier, and they might spontaneously disclose to you. And so this can include many different kinds of contact. It could be that you just speak with a parent. It could be that you also speak with the child. It could be that you have to make a report to law enforcement and or Child Protective Services, that you have to do some assessing for safety or risk of imminent danger as well. And so the next part, I'm going to hand the baton off to Dr. Guinn, and I'll let you go.
Yep. Does anybody have any questions before I get started?
No questions so far.
Great. I have nothing to disclose, so we'll move on from there. And I'm going to be talking about the importance of the medical history in child sexual abuse cases. And physicians, pediatricians, family practitioners, nurse practitioners all have a very important role to play in gathering information about potential sexual abuse of a child, because we're often first responders in these cases. So what kind of prompted us to want to educate others on this is we had a recent case of a 4-year-old child who was seen by the pediatrician for the parent was concerned about sexual abuse. Again, the child was 4. The medical provider talked to the child alone and asked questions about the abuse. Afterwards, the child did answer the questions, but afterwards, the medical provider determined that the child was not credible, and he documented that in the chart. Thankfully, he did make a report to CPS, and they took the case, but it was really confusing for them because here they had a professional who was saying the child was not credible. You know, what do we do with this information? It's all documented. But the child did come to the Child Advocacy Center and made a credible disclosure, and so they were able to take action on the case. Thank you. So why might a child come to a medical provider for concern of sexual abuse? Most obviously, there's a disclosure of abuse, perhaps to a parent or caregiver, and the caregiver makes an appointment and brings the child to the pediatrician to assess this. Sometimes there may not be a disclosure, but the parent, for some other reason, is concerned for abuse. It may be related to symptoms the child's displaying, like behavioral symptoms, could be something very specific, like sexualized behaviors or something they said, or it could be some kind of non-specific behaviors like not sleeping as well or not eating as much. There may be physical symptoms or signs that the caregiver is concerned about. We see a lot of caregiver concern for redness in the genital area, but there may be something like pain with urination or blood in the urine or something like that. So there may be a behavioral or physical sign or symptom. There are cases in which abuse is witnessed. Sometimes we see parents bringing kids in that they've, walked into a bedroom at home and saw the child and the cousin or something, and they witnessed something going on, and so they bring the kid in for evaluation. There may be concern for STI and pregnancies. We see this a lot with the teenagers who are trafficked. They kind of come in repeatedly for STI testing, or every time they come in, they want a pregnancy test. So when we see kids like that, we have to, ask why are they repeatedly having this worry for STIs or pregnancy, and so some further questioning and screening needs to be done. Kids may exhibit sexualized behaviors, and I'll go over that in a couple of minutes, or there may be a perceived abnormal anogenital finding. We see a lot of cases of kids going to the pediatrician with concern for the caregiver, grandma is changing the child's diaper and feels like the opening looks enlarged, and could this be a sign of sexual abuse? So they bring them into the pediatrician. So we have to approach these cases as we do as medical providers. First thing we want to do is take a medical history and get the information that we need. And the classic medical history involves the chief complaint. Why is the child being seen? History of present illness, more details about the chief complaint, past medical history, including medications, allergies, other medical conditions, family medical history. Social history often gets forgotten, but it's really important in these cases. And then finally, the review of systems. So all that takes place before any exam. So we're going to tweak that classic medical history for the times when a child comes in and there's concern for sexual abuse. So we first want to ask the caregiver, the person with concern, like what led up to having this concern of sexual abuse? Is it something that somebody saw? Is it disclosure from the child? Is it you're just worried about the person, that child was with yesterday? Those types of things. And it's important if the child does disclose to a parent, how did the parent react? Do they have any concerns regarding the allegations? And then there's the complete medical history for the child, like we talked about. But with sexual abuse cases, we really want to, during the review of systems, focus a lot on the genitourinary and GI symptoms, because this is often symptoms that children display when they've been sexually abused, but there may be no symptoms at all, and that's very common too. So, and then the social history, because we want to determine safety of the child, like who lives in the home, who cares for the child, is there daycare, and who is the child exposed to. So with the specialized questions in the review of systems, we phone's ringing. We want to ask about genital urinary complaints, more specifically pain with urination, blood in the urine. Sometimes there's blood in the underwear or blood when the child wipes, any change in toileting habits, bedwetting or daytime accidents, especially when these are a change in behavior or a new onset. Any type of vaginal discharge or rectal discharge. We also want to know if there's a history of accidental injuries to the genital urinary area, because if we look, we kind of want to know what baseline we're coming from. And then also to ask about hygiene. Do they use bubble bath? Because sometimes the complaint might be like itching or a rash. And so many times this is not sexual abuse, but just more hygiene related, chemical irritation or other infections. So we kind of wanted to know about all those things. GI complaints, maybe a little less specific than the genital urinary complaints, but abdominal pain, difficulties with BM, like pain with bowel movement, bleeding with bowel movements, or just rectal bleeding even without a bowel movement, and then encopresis or withholding of stool.
Didn't do a thing, huh?
You got stuck. There we go. Okay. So I just wanted to say a word about sexualized behaviors. Pediatricians get asked these types of questions a lot because parents become concerned when their little baby starts touching themselves or things like that. So they've done studies on large numbers of kids and kind of have determined in general what sexual behaviors are normal for certain ages and what are outside of the realm of normal and more concerning for sexual abuse or exposure to adult sexual activity. So in infancy, of course, oral gratification, they're always sucking on something, but little babies can get erections. And then as they get a little older and can reach their genital area, they will touch it, and they probably think it feels pretty good, so they keep touching it. And that's a normal behavior. As kids get older, they like to run around naked. That's pretty normal. And then more towards 3 to 6 years of age, they start to understand that there's a difference between males and females. They get very curious. Again, masturbation is common in this age group. And sometimes they like to touch like the breast of the mother or genital areas like over clothing. And then as kids get even older, 6 to 7 years, they begin to develop some boundaries and some modesty. They're still interested in sexuality, but they do things more in private. And then puberty and adolescence, of course, everything goes out the window, and they are become sexual beings. And then things we worry about, though, are these abnormal sexual behaviors that are outside the realm of normal. So these are the more explicitly sexual behaviors. They can be more like obsessive. So actually putting the mouth on sex parts, asking to engage in sex acts, masturbating with an object or inserting the object into the vagina or anus, imitating sexual intercourse or making sexual sounds, trying to kiss with tongue, actually undressing other people, wanting to watch explicit shows on TV, or imitating sexual behavior with dolls. So these are the kind of behaviors where the question needs to be asked: could this child have been sexually abused, or have they been exposed to pornography or adult sexual activity? because the child seems to know more about sex than they should at their age group. So medical providers are special people, and sometimes we find that kids are more willing to talk to their provider than they are, say, to their mom or dad or aunt or uncle. And that's because if a pediatrician or medical provider has been seeing this child since birth, they kind of have an established relationship with them, and they develop trust. The provider is also neutral. It's not, they don't get upset when you tell them things, where kids worry that if they tell mom something's going on, it might make her upset, or it might, affect the family. So provider is a more neutral type of person. So they may be more likely to be honest with the medical provider. Sometimes kids think, oh, the provider already knows because he's going to be able to see the changes on my body. And so, they just are more honest about what happened. Sometimes questions we ask, especially some of those review of systems questions, can prompt a disclosure. So you may ask a child, does it hurt when you go pee? And they're like, well, it hurts after my daddy puts his pee-pee in my pee-pee, and then it hurts when I go pee. So you may get some kind of disclosure related to a question you've asked. And then seeing the pediatrician can kind of be therapeutic, especially as we know most exams in sexual abuse end up being normal or nonspecific, and we're able to reassure the child and the family that their body's okay, and that if there's a problem, it can be treated. So some of the history questions that might prompt a disclosure, again, pain with urination, pain in the private area, difficulty with bowel movements, maybe even some nonspecific symptoms like trouble sleeping. How do you sleep at night? Well, I can't sleep because my brother keeps getting into bed with me and touching me. So, some of these just seemingly, just plain old questions might elicit a disclosure in a child. So, oh my gosh, what do you do if they actually disclose to you? You want to do the following. You want to document the child's exact words in quotes in the medical chart. You also want to ask enough questions to determine if you need to make a report to CPS and or police. Sometimes with the older kids who will separate from a parent, you can talk to the child alone and ask very, very open-ended questions, child-friendly language, and again, just minimal facts. What do you need to know to help determine if you need to report to CPS or police, or determine next steps, like sending them to a child advocacy center, and other types of follow-up. So the minimal facts involve really who did it, what happened, where did it happen, and when did it happen. And then if from these minimal facts, if you find reasonable concern for abuse or reasonable suspicion, you must report to CPS and or police as a mandated reporter. Most of the time, physicians think about the reporting to CPS, but sometimes we need to report to police as well, especially if there are safety concerns, and also if the abuse was done by a person not living in the home. So like a stranger assault, you would want to report to police as well as CPS. And never comment on the credibility of the child in the chart. That's really not, we don't need to worry about that as providers. That's for the jury to decide, or the investigators to decide next steps in the investigation. And then once reported, you can decide what to do next. We're always really welcoming providers to call and ask for any advice they need at the Child Advocacy Center. Most providers prefer to have the medical evaluation done at a Child Advocacy Center. And then we know there are advantages because, you know, the forensic interview can take place too, and all the coordination with investigators. There are some legal implications regarding what the child says during the medical evaluation. If they give an excited utterance, like one of our examples before, like it hurts to pee because so-and-so's been touching me there, you want to document that, and that's considered an excited utterance. Also, information obtained during the course of a medical history is admissible as well. So generally, the court does not allow statements that are hearsay, but these are exceptions to that hearsay rule. What about the exam? We follow NCA standards. The NCA is kind of the umbrella organization over the child advocacy centers. And their standard is that all children with reasonable concern for sexual abuse should be offered a medical exam. And that exam can take place at different places, preferably at a child advocacy center, but sometimes kids go to the emergency department and see a sexual assault nurse examiner, and some pediatricians are comfortable doing some of the medical evaluation in their office. We need to think about timing of the exam, like if the child's having a lot of pain or bleeding, they need to be seen immediately. If the abuse or assault happened within the past 72 hours for prepubertal kids or within 120 hours for pubertal children, exam needs to take place right away too, because there may be the need for forensic DNA evidence collection, which is time sensitive.
Do you want to add that the kits are also done at CACs? I think sometimes investigators think that sexual assault kits are only done by SANE nurses at SANE programs.
That's true. Yes. All the child advocacy centers in Wisconsin have the ability to do a sexual assault forensic evidence kit. And all the providers are trained to do these. So the only caveat is that we're open, 9 to 5, Monday through Friday. So if something happens after hours or on the weekend, often kids have to go to the emergency department. But sexual assault evidence collection can certainly be done at the CAC, and it's probably just a better, calmer place for it.
Well, I interrupted you on the physical abuse.
Okay.
Sorry, Dr. Guinn.
Yeah, that's okay. Just a word about physical abuse. It's not all sexual abuse, but sometimes kids are brought in to the medical provider. The parent may be concerned about an injury and concerned for physical abuse, or an injury might be discovered during the physical exam. And so if we see an injury that we're concerned for abuse with, again, you want to use those kind of minimal facts standards, and just really open-endedly. And this is what we do at the Child Advocacy Center too. We just point to the injury and say what happened here. And then oftentimes, the child has a visual, they know what you're asking. And so, oftentimes they will tell us how they got that injury. If they don't tell us right away, we never want to badger a child, or you can't make a child tell if they're not ready to tell. So, but we do give it a try. And oftentimes they will tell us. Then we want to document again, word for word, what the child said. And then something kind of newer is photographing, because with electronic medical records, it's so much easier to take a photograph and put it in the chart. And then you have that finding memorialized with a photograph. And oftentimes providers will call us at the CAC and say, I saw this kid, she had this injury I'm not really sure about, but I took a picture. Can you look at it and tell me if it's concerning? And we're more than happy to do that. So photographing is just about always a really good idea. And then again, making reports to CPS or police as needed. So just to kind of recap, the difference between a medical history and a forensic interview. As medical providers, we get to be focused on child health and well-being. So we emphasize, our questions are more directed at like bodily symptoms. We're more focused on diagnosis and treatment. So we do, the STI testing, pregnancy testing. We treat injuries if they occur. And then as a provider, we have to, have this information to determine next steps, reporting, any other referrals, maybe to therapy or further medical testing, or maybe seeing another medical specialist. Again, so important to reassure the parent and child of normalcy in the sexual abuse exams and ability to treat if needed. So again, that kind of therapeutic role. Forensic interviewing, and probably Amanda, you could speak to this better than I could, but it does take a specially trained interviewer. There are trainings throughout Wisconsin where a person can get certified. Is that what it's, or no?
So there's a 40-hour or 5-day training for the Wisconsin Forensic Interview Guidelines that is specifically geared towards forensic interviews working at child advocacy centers or investigators who investigate child abuse allegations, including law enforcement and human services. So it is not open to people that just, are looking to improve their questioning skills. It is really geared towards people that are going to be doing that recorded forensic interview. However, there is another training, which I'll let Elizabeth comment on at the end, that is available to the multidisciplinary team members that will not be doing forensic interviews.
Yep. Forensic interview is ideally recorded, but it's more focused on investigation. Did abuse occur? Who did it? What happened? It's not medically focused though, but like police determined, did a crime occur? CPS is tasked with, is the child safe? So it's kind of these types of medical history and forensic interviews, they have different focuses, but they all do come together in the end in a complete evaluation of a child who may have been abused. So I think we probably beat the drum hard enough, Amanda, but a CAC really is that one-stop shop. It's focused on the child and their well-being. So everybody comes together for the child. Things can be coordinated. They can have a forensic interview and a medical evaluation, all on the same day. The medical providers all are very highly trained and expert at what they do. We have the equipment to do these specialized exams, like the colposcope and fancy cameras. And very importantly, we're experienced and willing to go to court on these cases.
Just regarding court, I wanted to say that I think that that's one of the biggest points is that, many of us are probably comfortable talking to children, but we talked about today with our group here at Lakeshore CAC, we all are responsible for only doing what we're willing to defend in court. And, if you know that there's an opportunity that could happen, it should really be limited to the people that have the experience doing that, or as I would say, are battle tested to do that, because that is quite challenging and quite complex and can really be anxiety provoking if it's not something you do on a regular basis. It can even be anxiety provoking for some of my staff who do it on a regular basis. So don't do it unless you have to, I guess. So what can you do? So in addition to the framework that Dr. Guinn so eloquently provided, before you even speak to a child, determine if you need to speak to the child. And a lot of times you will as part of medical history, but there might be times where you don't. And when you're questioning that non-offending caregiver, as Dr. Guinn said, or also we could call them the protective adults, that means not the suspected maltreater or not someone that you think may be the alleged maltreater, but you should be trying to have that conversation with the parent without the child listening. If that's not possible at your office, certainly do what you have to do, but try to have that conversation without the child listening, and then determine if you do need to talk to the child. There might be some children that are young enough or have already been articulate enough that part isn't needed. You don't need to ask those questions, and in those times we ask that you don't. And be thinking about circumstances where the child would not need to be interviewed in the field or questioned about the abuse allegations in your office. I would say that if a caregiver is presenting a child and saying, I walked in and saw her mom touching her genitals, then the caregiver has already provided that information to you. That is enough to report. Do your exam, do the medical history, speak with the child as you would typically, but you do not need to, if the parent has already provided those who, what, where, whens, you don't need to ask the child about it. And we do want to be able to preserve the statement of the child. So it's important to limit the number of times they are questioned about the allegations, and it's important to be very cognizant of how we ask those questions. And sometimes you will have to talk to children. That's probably not as surprising to you, but I also do these slides for law enforcement. And so sometimes they think, oh, there's the CAC, I don't talk to a kid at all. If I show up to a house and there's a kid, I just leave. I'm exaggerating, but there are some jurisdictions where we've had to say, no, you might actually have to talk to a kid. And it might be if there's a spontaneous disclosure, like the girl we described in the beginning. You'll still talk to children during the standard communication you would have with the child during an exam, and there might be other times. So, for example, my children's pediatrician is also part of a sexual health and wellness initiative in Cedarburg. So Dr. Dan Hagerman is regularly part of conversations with tweens and adolescents about sexual health. So the chances that he might have crucial conversations with children about these things are pretty high. So I think he's a good example of how that might happen. So why can't you interview the child? And this question is a tale as old as time. So I have also been part of this WCASA SANE training for years. And years ago, I was asked by a SANE nurse, why can't I do the interview? And I was really stumped. I didn't know how to respond in a way that was respectful, in a way that really communicated my thoughts and opinions, and I do acknowledge that there are other states where the medical provider is also the forensic interviewer. That is not the case in Wisconsin. So we don't want to over-interview the child. I think that's the first important piece. But the other piece, and what I would say today if I was doing a training and someone asked me that, is why can't I do the medical exam? I can't do the medical exam because I don't have medical training. I don't have medical education. That is not my experience. My experience is as a social worker, an investigative social worker, and a social worker who talks to children. So that is my skill set, which is what helps me to be a good forensic interviewer. Just like I would never be asked to do the kit, because that's not something that's in my wheelhouse. It's not something that I would begin to know how to do, nor would I want to. So it's not for me. But we have to be ever so careful about how we talk to children, because over-interviewing can cause a lot of problems. It can change the child's statement, for example, without meaning to. If a child is asked the same question over and over again, what do you think they start to think? Is it possible that they start to think, I must be saying the wrong thing? I have to say something else. It could be that they end up recanting. We had that very scenario just happen here yesterday. A child who was caught caught, she wasn't caught. Her caregiver was caught sexually abusing her. And she came in here today and refused to speak for 40 minutes. She was 15 years old and just refused to say a word. So she just completely denied. And the other thing is that it can cause trauma. Continued interviewing can cause trauma to a child. So things to know, and I say all this because I want you to, even though you're not responsible or tasked with making a credibility decision, nor am I, like Dr. Guinn said, that is something that is up to the fact finders. We expect children to wait to tell. That is normal. Children don't tell right away about abuse, and how long they wait to tell, or if they tell at all, is very personal and very individual. And then the other piece is that piecemeal disclosure is the norm. A child might tell their mom that dad touched their butt, and the child might come in for a medical with you and say that dad put his pee-pee in her butt. And then that child might go to a forensic interview and say that dad put his pee-pee in her butt and her mouth. So those things don't mean that child's not consistent. Those things could mean that all of those things happened and they just have had the opportunity to think about it more. It could be that they were gauging how adults reacted when they told. So again, the provider being really warm and appropriate with the child is ever so important. And all of these things are influenced by, all of those factors around a child that we don't have control over. Has someone told them what to say? Did someone threaten them or coerce them? Did someone try to bribe them and tell them they would get something? I've had a child come into an interview room and essentially say, yeah, this happened, but I don't want to tell you about it because he pays for my cell phone. So I think it's just important that there's so many pieces up in the air that we oftentimes, I assume we only know a sliver of all there is to know about a child's situation. Things to remember though, if a child does disclose, listen and don't interrupt. So don't cut them off and say, you're not supposed to talk to me about this. You have to talk to somebody else. And I know I'm being a little silly, but it is important to let them talk. If the child seems anxious or unwilling to speak, do not make them talk. If they don't want to tell you about it and you can carry on with your exam without that piece of information, we would advise that you do that. It is not like talking to your own child at all. This is a different skill set. Trust me, I have 2 children that I talk to very differently than the children I interview. And as Dr. Guinn said, just to echo, only what you need to know, and always collaborate. If you're not sure, you can always call law enforcement. You can always call human services. You can also call a child advocacy center and consult as well. I fielded a call, several months ago from a nurse in the ER in Sheboygan who had seen a child for a medical exam. And at the time of medical exam, the child was having pain with urination and made a disclosure during the exam that someone had touched her private parts. So she was calling the CAC to consult and find out what she should do, who should she refer to, and that's okay. And we want those connections to happen. So as I just said, when in doubt, you can always call Child Protective Services or Human Services and our law enforcement. And you can also, if you know that that's something that's going to happen, you can prepare the family. You can say you're going to have to go to another place called a Child Advocacy Center, and you can talk to them about it. Like they're very nice there, or you're going to have to talk to someone there too, or you might have to have another checkup with another doctor at a special place. So work out the things you might say to a child or family about that. Once a CAC medical is completed, the report is available in the electronic medical record. I'm not the expert on how accessible those are. Dr. Guinn, do you have any?
They're pretty accessible to other providers, and now with the CARES Act, our medical reports are accessible to parents as well. So that's something to keep in mind. There are ways that you can keep the parent from seeing the medical, your medical report if you think it's going to cause harm to the child, or affect the safety of the child or hamper the investigation. But yeah, our medical reports are pretty visible. So if you have access to the electronic medical record.
And I show this picture because this is how the forensic interview files used to look. It's obviously not how they look anymore, but I like to remind everybody that I'm old enough to remember these as well. So CAC interviews are typically only available to the investigators at the time the investigation is open. If you are a primary or you are treating a child and you feel like that's information you want or might need, certainly reach out to the investigative team and find out. I mean, there are ways for us to share information about the forensic interview, although typically the interview itself is not available, and those are not in the medical record.
And I should say that for investigators to get the medical record, they do have access to them because it's a child abuse investigation, and they should contact the medical records department at the place where the child was seen.
And these are just a list of some of my favorite resources, other resources for training. If you're not familiar with those, they're all fantastic. National Children's Alliance, as Dr. Guinn pointed out, is our kind of national professional organization over CACs. They are fantastic. I also really like the National CAC, which is that last one. They have an annual conference that is the best one I've been to. It's fantastic. And they also have an online library resource that keeps, it's called Calio, and it tracks all of the articles, scholarly articles that are available as they relate to child abuse. So that is another fantastic resource. And they have lit reviews that you can pull as well.
And these are some of the medical references that helped me with my presentation. So these are all journal articles that you can find.
So we've reached the end, so this is really the opportunity for people to ask questions they might have, or Elizabeth, if you have things you want us to touch on, now might be the time for us to do those things.
Well, there was one more of a comment in the chat. Our CAC does not do evidence collection. They are partnered with the SANE program, and the patient is brought to the hospital. Both CACs we partner with don't have services for medical on site. And I just wanted to comment on that. CACs in Wisconsin, if they are accredited or working towards accreditation, part of the NCA accreditation standard is not necessarily that you have to have medical on site, but that you do have some sort of linkage agreement with a provider in your community. So not every CAC in Wisconsin does have on-site medical. Not every CAC in Wisconsin has on-site medical all the time. A lot of times it's just certain days, but a lot of flexibility there, especially if there's a delayed disclosure, that you'd be able to schedule out a medical exam with that child, whether it's at the time of their forensic interview or else. Anything you wanted to add, or?
No, thank you for clarifying that. I think I always think of the Children's Wisconsin Child Advocacy Centers, and because we're, you know, with the hospital, we all have sort of a medical emphasis. So all of them have medical providers that can do these evaluations, but you're absolutely right. I mean, a lot of CACs just kind of contract out. They may use, you know, a different child abuse pediatrician or a SANE provider to do their medical. So thank you for correcting that.
Oh, sorry, go ahead.
I was just going to add that, you know, the reason I brought that up is because Lakeshore CAC is in a blended area where some of our area has access to children's, and some of our area uses predominantly SANE programs. And what I really wanted to stress is, like, in the hierarchy of choosing what sort of medical response a child needs, if there are concerns of abuse, as Dr. Guinn pointed out, as the recommendation from the NCA, a CAC medical should be the first choice. And if you know you're in an area where they don't do kits, that's a different story. But short of that scenario, the first stop should be a CAC if it fits in the timelines and if you know that they have the services available. We have a very good working relationship with our local SANE program, and even they would say that the first option should be the CAC if the CAC is available. So I think in cases where that can happen, every community has to make decisions about how they will triage, but that would be the ultimate goal in a case of a needed medical exam for a child.
Thanks, Amanda. One question, any concerns with confidentiality when photographing a mark or injury on a child?
Well, I know at Children's, when a parent signs consent to treat, photography is part of that. So we don't do a separate consent for photography. It's just part of the medical evaluation. And, dermatology takes pictures all the time. The emergency department, we're not the only department that takes photos. So often it is, part of the medical evaluation. So that consent is just in there. But for forensic interviews, it's a different story, right? Is there a special consent for that?
No, so well, each CAC handles that differently as far as how they proceed. So interviews of children regarding child abuse happen in many different settings with the involvement of human services or law enforcement. And as far as what happens at the CAC, that is very individual to each center.
And I was speaking about Children's Wisconsin, so I'm separate from you. But different hospitals may have different rules. So maybe Aurora or another hospital does require a separate signature. So I guess always check with the place that you work with.
I just wanted to add to, Amanda had mentioned training for multidisciplinary team members. That's not that their primary duty is not necessarily doing forensic interviewing, and information about that is available on the CACs of Wisconsin website. So cacsofwi.org/resources, and you can find information about those trainings as well.
Thanks, Elizabeth.
Another question came in. Sexual assault over age 14 can sign for SANE exam, can sign for photos too, right?
I know that over 14, if you're dealing with reproductive health, that they can consent for themselves, like if they want an HIV test or if they are going to have an evidence collection. But I do not know about the photograph thing. I think, well, I know you're considered a minor or a child until you're 18. So I believe, at Children's, you would still need parental consent or consent on file to be seen. So the photography would be part of that. And so, we would assume that it would be okay to take, photographs of an injury or something like that. But, if a child said, no, I don't want, that's what happened to me before, I don't want a picture taken, I don't want colposcopy, we really honor, the child's wishes. We may, of course, educate them as to why we think it's important to do pictures or the colposcopic recording, but it's the child has all the power with our medical evaluations. So
thank you. So thank you, Amanda and Judy. I'll ask that you leave the attendance slide on the screen for a couple minutes. Attendees, if you have not already done so, you may now text the attendance code and complete your evaluation. Please join us for next month's webinar on commercial sexual exploitation of children. And thank you for being with us today.
Yeah, thanks everybody.
Thanks everybody.